Morning, everyone. Thank you to Antoinette and Beth Oliver for hosting this symposium. Today I will be discussing alcohol septal ablation, but first I would like to discuss cardiomyopathy because they kind of go hand in hand. Let's see, hold on, okay. So cardiomyopathy is a group of disorders primarily affecting the myocardium and characterized by myocardial dysfunction that is not the result of coronary atherosclerosis, hypertension, valvular dysfunction, or pericardial abnormalities. So there's no hypertension, there's no aortic stenosis, and there's no chronic renal failure. The specific types include infective, metabolic, familial neuromuscular disorder, sensitive or toxic reactions, for example, alcohol and chemotherapy. So for classifications, we have hypertrophic, which is left ventricular hypertrophy without an identifiable cause. Hypertrophy is predominant over the proximal anteroseptal wall. For hypertrophic obstructive cardiomyopathy, the obstruction is within the left ventricle outflow tract, or LVOT. For dilated cardiomyopathy, it's characterized by a low EF, and restrictive cardiomyopathy is characterized by restrictive filling of the ventricles. So you have the contractile function of the heart and the wall thickness are usually normal, but the relaxation or filling is abnormal, and this causes a backup of fluids into the atria. So when we look at the types of cardiomyopathy, if you look here in this corner, you see a normal heart. The ventricles are normal, the septals, and the walls are of normal size. When we talk about dilated cardiomyopathy, you can clearly see that the ventricles are thickened and they're dilated. In hypertrophic cardiomyopathy, the walls and the ventricles thicken, but they also become very stiff. And in restrictive, they become stiff, but not necessarily thickened, as you can see there. So with hypertrophic cardiomyopathy, their pathological changes are muscular hypertrophy associated with fibrosis. The muscle fibers hypertrophy, there's muscular disarray in some parts of the heart, and the coronary arteries tend to be of larger caliber. Here we have an example of that. So on the left here, you have normal muscle structure. Everything is even and in alignment. And on the right, we have what we call the myocardial disarray. Everything is disorganized and just all over the place. Again, you can see here is a normal heart, the normal ventricles, the normal size of the septum and the walls. And on the right, we have hypertrophic cardiomyopathy. You can see the difference. The septum's extremely widened, and the walls are thicker. So with findings for hypertrophic cardiomyopathy, we have a dynamic LV flow outflow tract obstruction of at least greater than 30 millimeters and usually greater than 50. We have diastolic dysfunction, myocardial infarction, mitral regurg, and arrhythmias. For routine lab work, it's generally unremarkable. A chest X-ray may suggest left ventricular hypertrophy. An EKG can show left hypertrophy as well as pseudoinfarct pattern, meaning there's Q waves in the anterolateral leads, despite the absence of coronary artery disease. Patients with arrhythmias may demonstrate atrial fibrillation as well as non-sustained ventricular tachycardia. So again, here you see the normal chest X-ray of a person with a normal person. The heart size is normal. On the right, you see someone with hypertrophic cardiomyopathy, and you can see the difference in the size of the hearts alone. So the echo is a primary modality in diagnosing hypertrophic cardiomyopathy. It's used to elevate the septal thickness, the location and pattern of hypertrophy, the site and degree of LVOT obstruction. The continuous wave Doppler imaging can differentiate patients with cardiomyopathy from those with fixed obstructions. So most times patients present, they can be asymptomatic, they can have angina, syncope, dyspnea, or sudden death. So to treat these patients, it's mostly medical therapy is mostly for symptom relief. It has no effect on survival. We use beta blockers or calcium channel blockers. In regards to vasodilators, they decrease the afterload and may subsequently worsen the LVOT obstruction, so they must be used with caution, if at all. So for invasive treatment, that includes an ICD as primary prevention for the high-risk patients, a DDD pacemaker, alcohol septal ablation, which is a minimally invasive procedure, and surgical septal myomectomy. With the surgical myomectomy, it's an open heart surgery requiring the use of a heart-lung bypass machine to rest the heart while the surgery is being performed. It's performed by resecting a small portion of the proximal septum through an aortotomy right here, and you just remove the tissue. With alcohol septal ablation, it's a non-surgical, minimally invasive technique for septal myocardial reduction that provides dynamic hemodynamic improvement. It's a controlled myocardial infarction of the basal ventricular septum to decrease the gradient. And the septal artery is occluded with a balloon catheter, and alcohol is injected distally. So the indications are symptomatic patients with New York Heart Association class 3 to 4, drug-resistant angina, syncope, a resting LVOT gradient of greater than or equal to 40 millimeters, a provoked LVOT gradient greater than or equal to 60 millimeters if the resting gradient is less than 40 millimeters, and a basal septal thickness of greater than 15 millimeters. So this procedure was introduced in 1994 by Dr. Ulrich Sigwart as a less invasive alternative to surgical septal myomectomy. Originally targeted to a population of symptomatic patients who were thought to be non-surgical candidates. And the procedure has undergone significant technical refinements, most notable of which is the introduction of myocardial contrast echocardiographic localization of the target area. So the echo is used to clearly define the first septal off of the LAD. It's performed percutaneously in the cath lab. There's arterial access is obtained, and a coronary angiogram is performed to define the septal artery. And hemodynamics are reevaluated with remeasurement of intercavitary gradient. There's simultaneous pressure measurements performed in the LV and the aorta, and the physiological provocation of the gradient is then assessed with the Valsalva maneuver and by checking the Brockenbrough sign by inducing a ventricular extrasystole. So the Brockenbrough is a decrease in the pulse pressure after a premature ventricular contraction. So here we have an example of, in the red you have the aortic pressure, and you have in the blue here the left ventricular. You could see the distance between them, which is the gradient. So the aorta is about 130, the LV is about 270, so approximately about a 140 millimeter gradient. Here we have this PVC, and the first beat afterwards is what we call the Brockenbrough sign. You can see that the LV went up significantly, the AO went down a little bit, but you can clearly see the gradient is much bigger now. So with alcohol septal ablation, the venous access is obtained in the event that temporary pacing is needed. A coronary angiography is performed to exclude severe coronary artery disease and to locate the first septal perforator. An echogram is performed with contrast to visualize the perfusion area for the alcohol injection. Once the target area is defined, a slow injection of 98 to 100% alcohol is injected slowly into the catheter. The high concentration of alcohol is delivered directly to the thickened heart muscle and left in place for several minutes. While this is occurring, the patient may experience chest pain, and this is an indication that there is ischemia taking place and that the alcohol septal ablation is working. The effect of the controlled cell death at the targeted location is immediate, as thin scar tissue starts to improve blood flow to and away from the heart. So here's an example of an alcohol septal ablation. You can see down here when the alcohol is being infused, and this is the area of induced alcohol infarction. So individual studies suggest alcohol ablation may be useful in patients with no resting gradient, but a provocative gradient of greater than 30 millimeters. Some patients who do not show initial benefit can respond late and develop a reduced gradient at 3 months after the procedure. A myocardial contrast echocardiography can accurately show the size of septal vascular territory and predict infarct size from alcohol ablation. The use of MCE has been associated with greater success and less complications. So this graph is showing the top bar is LVOT provoked, and the bottom is at rest. And at baseline, you see the significant difference, and up to 24 months out, you see the significant decrease. The New York Heart Association class, also at baseline is high, and 12 months out, you can see another great decrease with alcohol septal ablation. So now, potential complications. Of course, every surgery has complications. For alcohol septal ablation, it includes complete heart block requiring a permanent pacemaker, which occurs in about 14 to 25% of the patients. A left bundle branch block or first-degree AV block prior to the procedure are significant predictors, as are injection by bolus, no use of MCE, and injection of greater than 1 septal artery. The benefits of alcohol septal ablation are not diminished in patients who experience complete heart block. Other complications include ventricular arrhythmias, coronary dissection, pericardial effusion, and rarely late myocardial infarction due to escape of alcohol from the target vessel. So the advantages are the avoidance of sternotomy and a cardiopulmonary bypass machine, as well as their associated risks, shorter hospital stays and recovery time. And for older patients, there is less risk of stroke with alcohol septal ablation than septal myomectomy, and it's less costly. So for a case study, this is a patient. She was a 74-year-old female. This shot is indicating we're just getting the coronaries, defining the first septal. Here you can see the first septal is defined, and we have a wire there getting ready to advance the alcohol septal ablation catheter. And you can vaguely see the catheter right here. It's in the location where it's supposed to be, the first septal, getting ready to induce the alcohol. And here you can see the alcohol is being injected. And we just once the alcohol is injected, remember, we keep the catheter in place for a couple of minutes just to make sure that we just monitor the patient to make sure that everything is good, that the alcohol went through. And then this is a shot showing that now you can see the septals are gone and the anatomy is still okay. There was no blockages or anything after that. Now, so then we also take measurements after the procedure, and you can clearly see the gradient has gone down drastically. It's about 150 and 210, so it's about a 50 millimeter gradient difference. So it went from 140 to 50 immediately after the procedure. And still, about 10 minutes later, it still continues to decrease, which is a good sign. So in conclusion, alcohol septal ablation has developed as a safe and attractive modality to treat patients with hypertrophic cardiomyopathy. The procedure has been refined over the past decade with steadily increasing outcomes. And when compared to surgical septal myomectomy, the benefits of alcohol septal ablation include shorter hospital stay, less pain, and the avoidance of complications associated with surgery and cardiopulmonary bypass. And thank you.